Welcome back to this course on ACL injury rehabilitation, the week 4 intermediate phase. Lecture 20, kinetic chain deficits and psychological readiness during ACL recovery, addressing the weak links and being mentally prepared to move ahead. I am Dr. Jaren Shaji from the Department of Sports Medicine, AFMC Pune. In this lecture, we will be going to the details of addressing various kinetic chain deficits and also psychological readiness in ACL injured athlete during the intermediate phase of the rehabilitation process. The learning objects of this lecture are to revise the kinetic chain concept with regards to foot, ankle and hip influence on knee, to address various common compensatory deficits, to see the psychological barriers to return to sport, to see some assessment tools like IKDC and ACL RSI scale, to see various strategies for psychological readiness, the kinetic chain concept. As we had discussed earlier, the kinetic chain describes how the moments and forces act at the foot, ankle and hip influence knee mechanics during closed kinetic chain tasks. Closed kinetic chain tasks are in which the distal end of the body is in contact with the ground or any other platform. For example, squats, walking, etc. The distal, that is foot and ankle, and the proximal, which is the hip part of the kinetic chain, may encounter various dysfunctions like poor dorsiflexion at the ankle and weak abductors at the hip. This can increase the chance of valgus collapse of the knee, which is foot going outwards away from the midline, and also alter tibial rotation patterns. These can heighten the stress on the ACL graft. Closed kinetic chain exercises best restore coordinated multi-segmented lower limb function, which are crucial for safe movement re-education in ACL rehabilitation. Now let's see various common compensatory deficits. Athletes often adopt abnormal compensatory movement patterns such as shifting the load from surgical side to the uninvolved leg, or recruiting hip extensors more than the knee extensors during daily tasks like squats and gait. This may be noticeable by observing the athlete, as in he might have a slight abnormal gait or a limb, but some may not be easily noticeable and found out only using tests. These persistent asymmetries can include decreased knee extensor or quadricep strength, over-reliance on hip extensors, reduced vertical ground reaction force under the surgical limb, and also altered gait biomechanics. These strategies may decrease ACL loading acutely, but they increase risk for secondary injuries and hinder true knee function recovery. Hence, it has to be countered or corrected. Now coming to various psychological barriers to return to sport. The psychological barriers, especially the fear of re-injury and the lack of confidence, are leading reasons athletes fail to return to sport despite their physical readiness after rehabilitation. Self-reported fear of movement, also known as kinesiophobia, pain catastrophizing, and uncertainty or self-doubt can alter knee biomechanics and reduce compliance or adherence to the rehabilitation program. Real or perceived comparisons with pre-injury performance, various social pressures, and doubts about the knee safety often persist into the later rehab stages. Now coming to various assessment tools for the knee, the IKDC scale. The IKDC or International Knee Documentation Committee Subjective Knee Form is a validated multidimensional questionnaire or a patient reported outcome measure which is used for assessing symptoms, function, and sports activity in ACL patients. This is a globally used tool for tracking rehabilitation progress and readiness. It was developed to assess both surgical and non-surgical outcomes across a wide range of knee conditions and treatment approaches. It consists of a total of 18 items, and each item is scored using an ordinal scale wherein a higher score indicates better function or fewer symptoms. Coming to the next assessment tool, which is ACL Return to Sport After Injury scale. We have just discussed about the scale during the last lecture, but for a recap, it's a 12-item tool quantifying psychological readiness, confidence, and emotional response to return to sport. Higher scores such as 65 to 70 correlate more than 65 to 70 correlate with successful return to sport. Various changes of more than 13 to 15 points reflect true change in readiness. Both these tools should be incorporated routinely to gain insight into both physical and psychological progress throughout the rehabilitation timeline. Now coming to various strategies for psychological readiness. Few of these are cognitive behavioral therapy. Approaches such as cognitive reframing, exposure therapy, and imagery or visualization helps to reduce fear and builds positive expectations around the movement. Next, coming to gradual exposure. Introduce progressive and sport-specific skills under controlled conditions to rebuild the trust and self-efficacy of the individual in the reconstructed knee. Peer or mentor support. Connecting with others who have successfully returned to sport supports motivation and addresses the sense of isolation. The feeling that you are not the only person going to the similar process motivates a person. Mindfulness and stress management. Meditation, breathing exercises, and structured review of readiness helps to mitigate anxiety and enhance focus during return to progression. Regularly use psychological screening tools to identify barriers and early and integrate targeted interventions from both physiotherapists and sports psychologists for a holistic rehabilitation approach. These are my references. Thank you very much and Jai Hind.